Hello, everyone. My name is Rachel Bauer, and I'm a research associate with the Pacific Institute for Research Evaluation. Today, I will be discussing the qualitative findings from our project that identified previously unknown impacts of COVID-19 among survivors of interpersonal violence, or IPV. We know from the literature that IPV is amplified by the co-occurring syndemic of COVID-19 and substance misuse, and women who have experienced or are currently experiencing IPV may be at higher risk for negative pandemic impacts, including psychological distress, reduced feelings of safety, and increased violence. While public health directives such as wearing personal protective equipment, or PPE, social distancing, and stay-at-home orders and other state and municipal sanctioned directives are imperative to reduce COVID-19 infection rates. There is little understanding of how these protocols may mimic the power and control used by partners who perpetrate violence by reducing social and tangible supports. These experiences may result in additional negative psychological and physical impacts, as well as re-traumatization. Generally, a broader understanding of the intersection of survivors' experiences with previous trauma can create pathways for practitioners to implement trauma-informed, community-based care. In the fall of 2020, female residents of an urban domestic violence shelter in a southern state in the U.S. were recruited to participate in in-depth interviews. Interviews explored the impacts of COVID-19, including personal experiences and changes in access to services and effects of COVID-19 in the context of IPV, HIV, and substance use. A total of 6 female residents completed the interviews. Interviews were conducted and transcribed via Microsoft Teams. Using the mixed method software Deduce, a thematic analysis approach was used to analyze the qualitative data and reach consensus on the coding scheme and identified themes. Findings were shared with the project's Community Advisory Board, women with lived experience of IPV and/or HIV, who resoundingly championed the idea and helped us construct a conceptual model that aligns with Duluth's model power and control wheel. This is the original Duluth model's power and control wheel, which includes tactics used by perpetrators of violence to gain power and control over their partner. This wheel was used to strengthen and ground our findings, as well as provide a comparison with which to view the impacts of COVID-19 on survivors of IPV and how it mirrors many of the elements of the cycle of abuse included in the wheel. Here we have the findings from our study displayed in a similar layout with the themes making up each wedge of the wheel and the supporting quotes around the outside. Our findings suggest a substantial overlap between the emotional abuse perpetrated by a controlling partner and the impact of public health guidance and fears of infection from COVID-19. For example, comparable to the bodily harm of physical abuse, postponing healthcare due to fear of infection or acquiring care in an overburdened healthcare system can result in adverse physical health effects. Power differentials or privilege between client and provider are intensified given the restrictions to healthcare access and strict protocols for accessing services. Like an abusive partner, COVID-19 restrictions limit access to sexual health care, safe sex supplies, and contraception choices. Support system access is limited by healthy at-home ordinances. Other commonalities, including the menacing appearance of PPE and controlling finances via employment status changes. These commonalities suggest a potential framework through which practitioners can understand and more directly address the possibility of reoccurring trauma due to COVID-19. Providers should capitalize on this opportunity to consider ways the pandemic has affected those they serve and provide a multifaceted approach to better meet their needs, especially those with a history of trauma, by including their voice when developing more nuanced public health and safety protocols. Given the limitations of this study, including small sample size and all participants residing in shelter, we caution against generalizing these results to a wider population. To our knowledge, the parallels between COVID-19 public health measures and IPV have not been explored, and these findings offer a new theoretical framework to the field. Future research should be conducted to confirm these findings and test its applicability for other kinds of trauma-informed care. I would like to thank everyone for attending this presentation, as well as our participants, partners, and funder, Office of Women's Health, for making this project possible.